9 out of 10 seniors taking this medication have no idea it is slowly erasing their memory. Not because the drug is rare, because it occupies a shelf in nearly every American home, sold without a prescription, trusted without a second thought. The damage is not dramatic. It does not announce itself. It just quietly chips away at the chemical your brain uses to form new memories. And by the time most people connect the dots, years of clarity are already gone. I have spent 15 years watching this happen in my emergency department. And I am going to walk you through the 9 most common culprits ranked from least to most dangerous, because the one at number one is not what anyone expects. It is not a single pill. It is what happens when several of these medications stack on top of each other at the same time. Stay with me, because understanding that one thing could be the most important conversation you have with your doctor this year. Before we get into the list, drop a comment telling me how many prescription medications you take every day. Just a number. That information shapes every video I make for this channel. Everything I share today is based on published research and 15 years of clinical experience. But your health is yours. Never stop, reduce, or change any medication without talking to your doctor first. Now, I want to be clear about why this list matters. These 9 medications all affect the brain through 2 main pathways. Either they block a chemical called acetylcholine, the messenger your brain uses to lock in new memories, or they disrupt the nutrients and signaling molecules your neurons depend on. The older you are, the harder the landing. By the time you reach your mid-70s, your brain's acetylcholine reserves have already dropped by 30 to 40% compared to your 40s. Anything that cuts into what is left hits harder and lasts longer than it would have a decade ago. That is the context. Now, let us go through the list. Number 9 is the one hiding in plain sight, diphenhydramine. You probably know it as Benadryl, the pink pill on the open drugstore shelf, sold for allergies, for sleep, for colds. It costs a few dollars, no prescription needed. And that accessibility is exactly what makes it dangerous, because most people assume that without a prescription requirement, the drug cannot cause serious harm. Inside your brain, diphenhydramine is not gentle at all. It is an anticholinergic drug, meaning it works by blocking acetylcholine. Think of acetylcholine as the ink your brain uses to write new memories. Block the ink supply and the writing gets faint enough, and new information simply does not get stored. The hippocampus, the seahorse-shaped structure in your temporal lobe, where short-term memories get converted into long-term storage, is particularly exposed to this effect. A 2023 analysis published in JAMA Internal Medicine found that regular anticholinergic drug use raised the risk of dementia by 54% compared to people who avoided this drug class. That is a 54% elevation from something most people reach for without thinking twice. Here is the practical move. Check the label on anything you take for sleep, allergies, or cold symptoms, especially anything marked PM, nighttime, or allergy relief. Those are very often just diphenhydramine in a different package. Loratadine, sold as Claritin, and cetirizine, sold as Zyrtec, do not cross the blood-brain barrier the way diphenhydramine does. They are safer choices for your brain over the long term. Bring the comparison to your doctor. Not to make a unilateral switch, but to have the informed conversation. Number 8 is the one your stomach loves while your brain quietly starves. Proton pump inhibitors, omeprazole sold as Prilosec, esomeprazole sold as Nexium, pantoprazole sold as Protonix. These medications shut down acid production in your stomach, and they are prescribed for heartburn, reflux, and the burning discomfort that follows meals. The relief is real, but the brain is paying a price, and almost nobody is told about it. Your stomach needs acid to extract certain nutrients from food. Vitamin B12 is the one that matters most for this conversation. B12 protects the myelin sheath. Think of it as the insulation coating every nerve fiber in your brain. Strip that insulation. Signals misfire. Neurons fall silent. Memory gaps appear. Over time, the cognitive effects of B12 deficiency look remarkably similar to early dementia, confusion, memory gaps, difficulty concentrating, when the real cause is a nutrient that has been blocked since the medication arrived. A large study in JAMA Neurology tracked more than 73,000 adults aged 75 and older. Regular proton pump inhibitor users showed a 44% greater likelihood of a dementia diagnosis compared to non users. And recent research has also linked PPIs to elevated levels of amyloid beta in the brain, the same protein that accumulates in Alzheimer's disease. Here is what I recommend discussing with your doctor. If you have been on a proton pump inhibitor daily for more than 8 weeks, ask whether an H2 blocker like famotidine, sold as Pepcid, might work for your situation. H2 blockers reduce acid without eliminating it entirely and without the same impact on B12 absorption. Also, ask to have your B12 level checked. It is a simple blood test. If your level is low, supplementation is straightforward and can make a meaningful difference. The goal is the lowest effective dose for the shortest necessary time, not a prescription on autopilot indefinitely. Number 7 is one most people never connect to memory at all because it is prescribed for a problem nobody wants to discuss. Oxybutynin, sold as Ditropin. It is one of the most commonly prescribed medications for overactive bladder, the sudden, urgent need to get to the bathroom that can reshape an entire day. The relief it offers is real, and the quality of life impact of overactive bladder is genuinely significant. I am not dismissing that, but oxybutynin is a potent anticholinergic drug. It crosses the blood brain barrier readily, and it parks itself directly in the regions where memory is processed. A large observational study published in the British Journal of Clinical Pharmacology found that older adults taking strong anticholinergic drugs like oxybutynin for more than a year had a 49% higher risk dementia. And here is the part that stays with me. Nearly none of them had been warned. They were told the pill would help their bladder. The cognitive cost was never part of the conversation. The important news is that you do not have to choose between bladder control and brain health. Mirabegron, sold as Myrbetriq, works through a completely different mechanism. It does not touch acetylcholine. For most patients, it provides comparable bladder control without the cognitive risk. Pelvic floor physical therapy is also highly effective for overactive bladder and carries zero systemic risk. Ask your doctor about both. This is a case where an alternative exists and simply needs to be requested. Number 6 is the most prescribed medication in America for adults over 60, and it carries a cognitive story that almost nobody tells. Statins, atorvastatin, simvastatin, lovastatin, rosuvastatin, pravastatin. These drugs reduce LDL cholesterol and lower the risk of heart attacks and strokes. They belong in many people's treatment plans. This is not a case against statins. This is the half of the picture that usually gets left out of a 7-minute appointment. Your brain is close to 60% fat, and it relies on cholesterol to build and maintain myelin, the insulating sheath, around every nerve fiber. Suppress cholesterol production aggressively enough, and you can deprive the brain of a foundational building material it genuinely requires to function. Here is the nuance that matters. Not all statins behave the same way inside the brain. Lipophilic statins, simvastatin and lovastatin in particular, dissolve in fat and cross the blood-brain barrier easily. They reach brain tissue directly. Hydrophilic statins, pravastatin, and rosuvastatin do not penetrate the blood-brain barrier as readily. A 2023 analysis in JAMA Internal Medicine looking at statin-type differences found that adults over 65 on lipophilic statins for more than 3 years showed a measurably higher rate of mild cognitive impairment compared to those on hydrophilic. Alternatives, the higher the dose, the more pronounced the difference. If you have taken a statin over several years and notice increasing mental fog, word retrieval difficulty, or a sense that your thinking is slower than it used to be, that is a specific actionable conversation to have with your doctor. Not about stopping the statin, about whether switching to pravastatin or rosuvastatin might give your heart the same protection with less exposure to your brain tissue? That is a question your cardiologist or primary care doctor can answer with your specific numbers in front of them. If what you are reading is connecting dots for you, tap like so. This reaches someone who needs it. And tell me in the comments, have you or someone you love noticed cognitive changes after starting a new medication? I read every one. Now, number five. Number five sits at the intersection of relief and risk, and it is one of the hardest to address because stopping it abruptly can be genuinely dangerous. Benzodiazepines. Lorazepam, sold as Ativan. Diazepam, sold as Valium. Alprazolam, sold as Xanax. This medication class ranks among the most widely prescribed in the country for anxiety and insomnia, and for the people who take them, the initial effect can feel like being handed a lifeline. The panic quiets, the racing thoughts slow, sleep comes. What builds over months is harder to see. Benzodiazepines work by amplifying GABA, your brain's primary calming signal. That sounds helpful. But GABA and acetylcholine work in opposition. When GABA is artificially amplified for months or years, the brain gradually compensates by reducing the sensitivity of its own alertness and memory systems. The result is a slow, cumulative sedation, not dramatic, not sudden, just a gradual dimming of sharpness that most people attribute to aging. A 2022 cohort study in the American Journal of Psychiatry followed more than 8,000 adults over 65 for 6 years. Those who used benzodiazepines for more than 90 days, even intermittently, showed a 51% higher rate of Alzheimer's disease diagnosis over the follow up period. Longer acting formulations like diazepam show the sharpest association, likely because they accumulate in fatty tissues, including brain tissue, over time. Here's the rule that matters most. If you have been on a benzodiazepine for a month or more, do not stop abruptly on your own. Abrupt discontinuation can cause rebound anxiety, seizures, and severe agitation. The consequences can be life threatening. Work with your doctor to taper the dose gradually over weeks or months. Cognitive behavioral therapy for insomnia, CBTI, has been shown in multiple trials to outperform benzodiazepines for long term sleep quality without the dependency risk. Buspirone can address anxiety through a different mechanism without sedating the brain. These alternatives exist. They are worth asking about. Number four is a medication prescribed for three entirely different problems. And because it sounds like it can do everything, nobody stops to ask what it is doing to the brain. Amitriptyline, sold as Elavil. It is an older antidepressant, but today it is more commonly prescribed for nerve pain, for sleep, and for migraine prevention. The versatility is real. The hidden cost is also real. Amitriptyline is one of the most potent anticholinergic drugs still in regular use. It does not just reduce acetylcholine modestly, it blocks it aggressively. And here is the detail that concerns me. This effect does not require a high dose. A modest nightly amount, taken consistently for months or years, can silently diminish cognitive function with no obvious alarm. The memory slippage is gradual. The word finding pauses are easy to dismiss. By the time the pattern becomes undeniable, years of cumulative exposure have already accumulated. A landmark study in JAMA Internal Medicine followed more than 3,400 adults over 65 for 10 years. Those with the highest cumulative anticholinergic drug exposure measured across the full decade had a 54% greater risk of developing dementia. The exposure did not have to be recent. It did not have to be high dose. It just had to be consistent. Amitriptyline was among the most represented drugs in the high burden group. If you take amitriptyline for nerve pain, duloxetine or gabapentin may offer comparable relief through mechanisms that do not block acetylcholine. For sleep, low-dose doxepin, which has a far gentler anticholinergic profile than amitriptyline, is worth discussing. For mood, sertraline and escitalopram are generally considered significantly safer for long-term brain health in older adults. None of these switches happens overnight, but the conversation is worth starting. Number three is the one I flagged at the beginning, and now you will understand why. Paroxetine, sold as Paxil, At first glance, it reads like a mild contemporary antidepressant, a selective serotonin reuptake inhibitor, which sounds far gentler than the older drugs. And for most SSRIs, that impression is accurate. Sertraline, escitalopram, citalopram, these do not carry significant anticholinergic activity. Paroxetine does. Paroxetine is the outlier in the SSRI class. It has measurable anticholinergic activity at standard therapeutic doses. That single characteristic separates it from every other commonly prescribed antidepressant in that family. And it means that for an older adult, it carries risks that most people taking it have never been told about. A systematic review published in Frontiers in Psychiatry in 2021 examined cognitive outcomes across different antidepressants in adults over 60. Paroxetine users showed measurable declines in short term memory and verbal recall within the first 12 months of use, and were 30% more likely to show early markers of cognitive impairment than people taking non anticholinergic SSRIs. The American Geriatric Society placed paroxetine on the Beers criteria, the formal list of medications considered potentially inappropriate for adults over 65, specifically because of this cognitive risk. If you take paroxetine, ask your doctor directly, is there a reason this specific medication is preferable to sertraline or escitalopram for my situation? In most cases, the answer is that the switch is straightforward. In a small number of cases, there may be a specific clinical reason to stay. Either way, you deserve the answer. Number two is the one that concerns me most from an ethical standpoint, not because the drugs are the most dangerous, but because the people taking them often do not know what type of medication they are on. Antipsychotics, quetiapine, sold as Seroquel, risperidone, sold as Risperdal, olanzapine, sold as Zyprexa. These medications were developed for serious psychiatric conditions, schizophrenia, bipolar disorder with psychotic features. They are powerful, and in the right clinical context, they are appropriate. Today, they are frequently prescribed off-label to older adults in nursing facilities and sometimes at home for agitation, for restlessness, for sleep, for behavioral symptoms in people with dementia. And many of the people receiving them never had the word antipsychotic used in their presence. They were told it was a medication for sleep or for nerves or to help with behavioral issues. A 2022 study in Lancet Healthy Longevity tracked more than 25,000 older adults. Those given antipsychotics for behavioral symptoms were 71% more likely to show rapid cognitive deterioration within 12 months, a finding that held even for participants who had no prior dementia history. These medications also carry FDA black box warnings for elderly patients with dementia-related psychosis, including increased risk of stroke, sudden cardiac events, and death. Antipsychotics suppress dopamine, a neurotransmitter involved in motivation, executive planning, and working memory. Reduce dopamine significantly, and the brain becomes slower, flatter, less responsive. Families watch this and think it is the disease progressing. Sometimes it is. Sometimes it is the medication. If a loved one is on an antipsychotic and you do not know why, ask. Ask the prescribing physician directly, what behavioral symptom is this treating? Has non-pharmacological management been tried? What is the plan for tapering or reassessment? Many behavioral symptoms in older adults respond to structured routines, reduced sensory overstimulation, adequate pain management, and improved sleep hygiene. Medication is sometimes necessary. It should not be the first, only, or permanent answer. Now we get to number one. And as I said at the beginning, it is not a single drug. Number one is the combination. It is what researchers call anticholinergic burden, the cumulative blocking effect, when several of these medications are taken simultaneously with no one calculating the total. Your doctor prescribed the bladder medication, your other doctor prescribed the sleep aid, the pharmacy dispensed the Benadryl because you asked for it. And none of the three conversations included anyone adding up the total chemical load on your brain's acetylcholine system. Here is a real and common scenario: diphenhydramine every night for sleep, oxybutynin every day for bladder control, amitriptyline for nerve pain in the legs. Each medication individually might produce only a small and barely perceptible cognitive effect. Together, they compound, and a compounded anticholinergic load does not just slow your brain modestly, it can push the system into a state that, on cognitive testing, is indistinguishable from early Alzheimer's disease. A 2022 population study published in Age and Aging tracked more than 280,000 older adults, those in the highest anticholinergic burden category, meaning the most medications with the strongest combined blocking effect, had a 120% higher risk of dementia within 10 years, more than double. And the vast majority of them had no idea they were taking anticholinergic medications. Nobody had ever used that word with them. Here is what you can do about it today. There is a validated scoring tool called the Anticholinergic Cognitive Burden Scale. It assigns each medication a score from 0 to 3 based on how strongly it blocks acetylcholine. A total score of 3 or more is considered clinically significant, associated with measurable cognitive impairment. Scores of 6 or above in older adults correlate with the kind of burden seen in these high-risk studies. You can look up each of your medications by name in this scale before your next appointment. Many pharmacies and online clinical tools can pull up the ACB score for individual drugs. Add them up. If your total is 3 or above, bring that number to your doctor and say, my total anticholinergic burden score is this number. I would like to review which medications in this list could be switched, reduced, or eliminated. That sentence, specific, clinical, actionable, is far more likely to prompt a real medication review than a general concern about memory. Now, here is the hopeful part, and this is the reason I made this video. Medication-induced cognitive decline is often reversible. Not always, not completely in every case. But in many patients, when the high burden medications are reduced or eliminated under medical supervision, clarity, word retrieval, and processing speed improve measurably within weeks to months. The brain is more resilient than most people are told. It is asking for the source of harm to be identified and addressed. This is also a case where involving your pharmacist makes a real difference. Pharmacists are medication experts. Many Medicare plans cover a medication therapy management session, a one-on-one review of everything you take. If you are on multiple medications, ask whether your plan covers this. It costs you nothing, and it is exactly the kind of systematic review that catches the burden problem before it causes serious, lasting damage. A study by the American Medical Association's journal found that 40% of drug-to-drug interactions and drug-to-brain interactions in older adults are missed in the standard primary care appointment. Not because the doctor's careless, because 7 minutes is not enough time to review 14 medications. Bringing a written list of everything you take, prescriptions, over the counter, supplements, vitamins, and asking specifically about anticholinergic burden changes, that dynamic. Let me tell you about Carol. She is 68, a retired postal carrier from Kansas City. She had been taking diphenhydramine for sleep for 11 years, oxybutynin for bladder issues for 4 years, and low-dose amitriptyline for leg pain for 3 years. She came to me because she thought she was developing dementia. Her ACB score was 8. We worked with her primary care doctor to replace diphenhydramine with low-dose melatonin and CBT-I strategies, switched oxybutynin to mirabegron, and transitioned the amitriptyline to gabapentin over 6 weeks. At 6 months, Carol said something that I write down every time a patient says it. I feel like someone turned the lights back on. Her total ACB score went from 8 to 1. Her memory had not disappeared. It had been chemically suppressed. I am not promising you Carol's outcome. Individual results depend on how long the exposure lasted, your overall health, and the specific medications involved. What I am telling you is that this cause of cognitive decline is among the most reversible in medicine, and it goes completely unidentified in millions of older adults every year. Here's what I want you to do this week: write down every medication you take, prescription, over the counter, supplement. Next to each one, write the ACB score if you can find it. Add them up. If the number is 3 or above, schedule a conversation with your doctor or pharmacist. You do not need a crisis to earn a medication review. You just need to ask for one. If you made it to the end of this video, type review in the comments and share this with one person in your life, your mother, your spouse, your neighbor, who is on multiple medications and has noticed their thinking changing. Your sharing this video might be the thing that gets them the right conversation at the right time. Next week, I'm going to show you something that connects directly to what we discussed today. There is a pattern I see on patients' lab reports, 3 specific numbers that, when read together, tell you your brain's vulnerability to this kind of damage years before symptoms appear. Most doctors look at each number in isolation. Looking at them together tells a completely different story. I will show you exactly what to ask for and what the numbers mean. This video is for educational purposes only. It does not constitute medical advice and is not a substitute for care from a licensed healthcare professional. The case study presented represents a clinical pattern based on real experience. Individual details are a composite. Never stop, reduce, or change any prescribed medication without your doctor's guidance. One more thing before you go. I want to give you the exact language to use when you walk into that appointment, because one of the most consistent things I hear from patients is that they did not know how to start the conversation. Here is what I recommend saying. I have been reading about something called anticholinergic burden. I added up my medications and my score may be around this number. Can we look at this together and see if any of my medications could be adjusted, replaced, or eliminated? That framing does 3 things. It shows you have done preparation. It gives the doctor a specific clinical framework to work within. And it signals that you are not asking them to simply stop your medications. You are asking for a collaborative review. A study published in the AMA Journal of Ethics found that 40% of clinically significant drug interactions in older adults are missed in the standard primary care visit, not because the physician is negligent, but because the average appointment for a patient on multiple medications runs 7 minutes. 7 minutes is not enough time to analyze 14 medications for combined anticholinergic effect. Your job is to bring that analysis to the table. Your doctor's job is to interpret it with your full clinical picture in front of them. That division of labor works, and it is how patients like Carol get the medication reviews they should have had years earlier. If you are on Medicare, ask specifically whether your plan covers a medication therapy management session. Many Medicare Advantage and Part D plans cover this as a zero-cost benefit. It is a dedicated appointment with a pharmacist, not a rushed add-on at the end of a visit, specifically designed for people taking 5 or more medications. It is one of the most underused benefits in the Medicare system, and it is exactly what this situation calls for. You now have the information, you have the framework, you have the words. That is more than most people walk into an appointment with. Use it. The next step is yours.